Now, I've mentioned this term a few times so far in this lecture, but ventilation perfusion mismatch or VQ mismatch is the most common cause of hypoxemia in clinical medicine. Ideal gas exchange requires matched ventilation and blood flow, but regional differences do exist throughout the lung. Disease states can disrupt this balance, producing areas that are relatively underventilated or underperfused. Importantly, VQ mismatch increases the alveolar arterial oxygen gradient, distinguishing it from hypoventilation. Low VQ regions, such as those seen in asthma, emphysema, or atelectasis, contribute significantly to hypoxemia because blood passes through poorly ventilated alveoli. These patients typically respond to increased FiO2, which helps correct alveolar oxygenation. In contrast, regions with VQ ratios greater than 1 do not significantly contribute to hypoxemia because excess ventilation cannot compensate for reduced perfusion. Hypoxemia, as a definition, refers to specifically the low arterial oxygen tension, not impaired oxygen utilization. It's critical to distinguish hypoxemia from hypoxia, which refers to inadequate tissue oxygenation. Understanding the underlying mechanism of hypoxemia guides diagnosis and management, particularly when evaluating respiratory failure in a patient who's hospitalized. Now, this is showing kind of a gradient or 5 causes of hypoxemia. We can see here that hypoventilation, decreased barometric pressure, shunting, VQ mismatch, and diffusion limitation. And then we can see our PaCO2, our A to AO2 difference, and then our FiO2. So hypoventilation and altitude-related hypoxemia are characterized by a normal A to A gradient and improve alveolar to arterial and improve with increased FiO2. Okay. In contrast, shunt physiology produces hypoxemia that does not correct with supplemental oxygen. That's what this is. So they don't respond to supplemental oxygen because blood is bypassing the ventilated alveoli entirely. That's the whole issue with a shunt problem. VQ mismatch and diffusion limitations typically show an increase in our A to A gradient and a partial, maybe not full, but partial response to oxygen therapy. So looking here, we can see this again, another representation of this table. So we have our A to A oxygen difference, alveolar to arterial. Normal, we're looking at a hypoventilation or altitude issue. Increased, we're looking at their response to oxygen. If it's responsive, we're looking to a low VQ. If it's not responsive, we're looking to a shunt problem. So overall, in an ideal lung, ventilation and perfusion are perfectly matched, and alveolar and arterial PO2 are nearly identical. In reality, though, regional variation creates small physiologic shunts. Pathologic VQ mismatch exaggerates this difference, producing hypoxemia. Systemic evaluation using the A to A gradient and oxygen response allows clinicians to rapidly narrow the differential and initiate targeted treatments. At the end, I just want to take a moment to look at our carbon monoxide dissociation curve. Again, carbon monoxide is different than carbon dioxide, but carbon monoxide binds hemoglobin with an affinity of over 200 times greater than oxygen. This dramatically reduces oxygen carrying capacity. Even low partial pressures of carbon dioxide or carbon monoxide can saturate a hemoglobin, shifting our oxygen dissociation curve to the left and impairing oxygen unloading to tissues. Importantly, our PaO2 may appear normal, so our oxygen of our arteries could appear normal, which makes pulse ox unreliable in this condition. This is why carbon monoxide oximetry is required for diagnosis, and where carbon monoxide poisoning can be really rapidly fatal if unrecognized. This was probably the most tricky lecture of them all, even though it had less calculations than some of our previous, because it really is getting into some of the physiology that is a little bit harder to conceptualize or visualize. So I encourage you to walk through these scenarios several times to really understand what's going on.